just to finish, some recommendation for nasolabial folds and marionette lines. You can use almost everything. I like to use Emervel deep when I want to go superficial, a little bit of Perlane in the nasolabial angle. For cheeks, I do my double layer pillars and bridges, Perlane, and then Emervel volume or Emervel deep in the more superficial layers. For lips, I completely eliminated all the other products. I only use Emervel lip now. For the tear trough, I like to inject directly over the bone with Perlane. Perlane give me a lot of projection, and then you can refine with Emervel Classic, especially in the upper lid or in the more superficial layer, or sometimes even with a lighter product. So keep calm and try Emervel. Thank you very much.
And Restylane too, because as I say, by the way, you talk about Restylane for tear trough.
Yeah,
I think for some colleagues which are really beginners to be very careful with Restylane in the tear trough.
I think that in the tear trough, you need a strong product, something that is really lifting. But you should put less than 0.2. Probably a little bit is enough. And the tear trough, I didn't put my slides on this because otherwise we can speak the whole day.
No, we can.
Your
flight is 7 o'clock.
The tear trough is an area of under-correction. So my tear trough patients, they are always under-corrected. I correct about 70%, and I wait 3 weeks, 1 month, and then I retouch in case I need more, because usually a little bit of swelling, a little bit of volume is created after the hydration of the product. So,
which is specific for Restylane line.
And so
with money or without money, the touch-up?
Touch-up is always for free.
Okay, this is great to know.
Do you have good prices at the beginning?
No, we were discussing yesterday about pricing. I think we can make a small detour. I think that we should change a little bit the way we charge. For a long time, we have been using to charge for syringe. I mean, 1 syringe, 2 syringe. But we are doing a different story now, because we are doing like surgeries. If I do the nose, I use 0.3, 0.4, but it's a very difficult treatment. You should know how to do it. It's risky. You should charge. If you do the nasolabial, it's 5 minutes. You should charge less. If you do a mid-phase, you're going to use 4 syringe. If you charge by syringe and you use 4 syringe, it's unbearable for the patient. You cannot charge 4 syringe like you charge 1 syringe. So you should charge
the risk also, and you should charge also the complications if it's
and some areas. When I do the upper lid,
this is risky.
This is risky. It needs experience. It takes about 15 minutes for each eye, and I have to do it in 2 times, where they pay 2 times. I just don't charge the retouch, but I say it's 2 sessions, you have to pay 2 times. And it takes time. It takes about 40 minutes to do both sides, and I will charge, because there are few doctors who can do it. They have to come to see you, and this is risky for you. The effect is wonderful, and it's long-lasting. But when you have a patient for nasolabial, you can charge less, because it's easy. You do it in 5 minutes. And so I think, especially for fillers, we should change a little bit our mind in terms of how we charge patients, because we're offering almost surgical results, and sometimes we combine with toxin, with threads, with lasers. So sometimes it's a more comprehensive treatment. So the charging can be.
But let's now imagine a scenario. The patient is coming to visit you for problem in the midfacial area, which actually are nasolabial fold in the beginning, small tear trough, a little loss of the volume in the malar region. She is in front of you. You are going to tell and discuss with her how you are going to give a protocol treatment and who's discussing about the price.
Yeah.
Because she's the visit time now, and she's coming for the procedure after.
That's a good point. I think that the first appointment is the most important, where you lose time speaking and explaining, but actually you gain time for future treatments. And what is important is to explain, not in depth, but very basically what happened with aging, and to explain our project. So we need to have our patient understand and agree to do the treatment. Then we schedule the appointments, 2, 3, with the secretaries, and they know how much they will pay each time, more or less. And they will...
You have a special paper with the patient, I don't know, a sketch.
Yeah, okay. Yeah.
With the area, the amount of each area to be injected.
More or less.
Because you should tell her the price. It's based on the number of cc used, milliliters, and the area treated, and the complexity, and the time lost in your office, because she needs to know.
It's when you do a blepharoplasty, you see your patient, you understand exactly if she needs fat removal, if she needs muscle removal, if she needs a cantoplasty, if she needs lifting of the tail of the brow. So when you give her the price, this comes from your evaluation before that you do in your mind, but it's very fast because you
Who's telling the price, you or your secretary?
Usually I give, especially for fillers, I give my patient...
fillers, let's talk about fillers now.
I give a range. I cannot be very precise, but I will say, okay, it will cost between 1,500 to 2,000 euro.
This is your actual price for a mid-facial area?
No, it depends. No, it depends on...
Let's say the smallest price and the highest price, to have an idea.
To have an idea, they can have an average treatment could be for the beginnings 600 euros, or at the end of the treatments they can get to pay from 1,500 to 2,000 euros for the full face treatment. But sometimes they get toxin, sometimes they get fillers.
Are you combining toxin or fillers in the same session, especially for the periocular area, for
never,
the reason
never.
of, this is very important,
Never.
Key point, don't mix in the same session
I always do first toxin and then fillers. Because you know, if you do toxin at the same time, you block the muscle movement, you block the lymphatic drainage,
and the swelling will be long-lasting. Absolutely important this. And the patient needs to know how long it will be the procedure, because doctor, I want to know how many times I will stay in the office and how I can go back to work. Let's talk about the mid-facial area.
Usually, if you respect the anatomy,
that say that you are the best doctor, I trust you and I'm coming to see you. And Emervel is the best line in your hand. You told me this.
Of course, today we will see a lot of bleeding, but usually they don't bleed, because if you're okay, you know where to go, you don't touch the vessels. But normally I say you will need 3 to 4 sessions. I will say 3 sessions and then 1 final touch-up. And
in between session, how long?
Minimum 3 weeks.
3 weeks. There is a special reason for that?
Especially because when I do the eyes, I prefer not to have patients swollen and treated before 3 weeks. So usually I do first toxin, and I do some, I can do toxin and I can do some deep injection over the malar. You can do it quite easily. Sometimes when I inject more than 3 to 4 ml of HA, I always recommend drinking a lot, 3 liters a day, sleeping with 2 pillows, and sometimes I prescribe a steroid just in case they have some swelling.
Antibiotics sometimes?
Only for special patients, or if I need some complex procedures. But if I do suspension threads at the same time, I prescribe antibiotics.
Suspension thread? What kind of suspension?
Silhouette or Aptos or this type of.
Let's talk about dangerous area. If you want to explain once again, just in simple words, where to stay away. Don't look to find where is a vessel or where is the emergency of the nerves.
The nerves, they are a problem, but not a big problem for me, because when we do a local anesthesia of the infraorbital nerve,
this is another important topic. Let's talk about local anesthesia, with or without.
I prefer to do it without, but sometimes I give a small bleb of local. because
at the access point of the cannula, for example, to reduce the risk
yes,
of the
but
vasoconstriction?
sometimes I go directly into the infraorbital just to give...
You create a sort of...
Yeah, to the infraorbital or to the zygomatic small bleb of local. And when you do a local anesthetic, you know, the dentist, the maxillofacial surgeon, they are very good from inside. I'm not good from inside, what I do from outside. You exactly want to go to the nerve.
But small amount, because it's going to change the volume
of
and
course.
the appearance. You are not going to evaluate really the area.
If you go to the nerve, 0.2 is enough because you block...
With or without adrenaline?
Usually with. But be careful with those patients who suffer from hypertension or they report problems with adrenaline. Sometimes it's safer not to use adrenaline in some areas like the lips or the nose. Never use adrenaline in the nose. But in general, for the eyes, I give a little bleb of...
What about EMLA or other creams? You think it's important to use it? It takes some time.
It takes time. It takes time, and when you do deep injections, they are totally useless. So they are useful. What we have told you today, it doesn't mean that we don't need to inject wrinkles anymore. There are some patients that we do volumes, and after that, they are left with some wrinkles in the perioral area and the periorbital area. Those wrinkles, we have to treat the wrinkles. If you do a fillers to treat them, you have to do traditionally as we are using for many years. So in those cases, EMLA can be useful. But if we inject deep, I think that you don't need.
Or if we are in a Galderma meeting, they have an excellent anesthetic.
Pliaglis.
Which is really an excellent, it's better than ELMA from my point of view.
There is some drawbacks from both products. EMLA give a little bit of vasoconstriction that sometimes is useful, and a little bit of swelling that sometimes is not useful. Pliaglis give sometimes vasodilation that sometimes is not useful. It's very useful if you want to do a laser treatment for capillary vessels. That is very useful because you see the capillary much better. But in the problems with those product is that patients usually don't know how to use them, so they put very little amount of cream and it's not effective, so they think it's not effective, they stop putting it. So you should have your patient 1 hour before in the office, and you have your nurse to prepare the patient.
What about the position of the patient on the table in the treatment? What do you prefer?
Almost sitting. I always mark my patients
sitting position.
Or standing.
Or standing is better.
Yeah, like a surgery. And I do the treatment more or less in this position because it's much more comfortable for the patient and even for, but it's much better to have a sitting position than a laying position.
But the ideal position is the patient in a sitting position, having all the time the possibility to, if the patient is to lay down immediately if something is happening.
And
what about post-injection? What do you recommend?
Nothing really special. You can put some antibiotic cream, some cream after, a little bit of ice sometimes for controlling the swelling. And I recommend avoiding too hot or too cold temperatures, sauna and so on. But the general recommendation, but especially when I do deep layers and I do the periorbital, I always recommend to drink a lot.
Not alcohol. No.
Not alcohol. I was in Prague last month, and they asked me if it was to drink beer.
Beer, yes.
But 2 to 3 liters of water, to sleep with 2 or 3 pillows in order to have the face up and not swelling at night. And if I see, we discussed a lot with some oculoplastic surgeons, some colleagues about giving or not giving a steroid after the treatment.
Oh, this is a very good point.
And my final conclusion is that I always prescribe a steroid pill, and I say, okay, look how it behaves after 6 to 8 hours. If you see some swelling, take it. Otherwise, you can try not to take the pill. But I always prescribe a steroid pill.
What about the patient coming without a history with other injection hyaluronic acid without knowing which kind of product? What is your approach?
This is a very, very good question. As long as you are sure that it's hyaluronic acid, you are safe.
Yes.
I would say safe. Every brand you can combine. The real problem is that you are not sure if it's hyaluronic acid. We have experience. I can judge if it's silicone, of course.
In the lips especially.
We have experience.
Italy,
we
yes.
can tell if it's silicone.
Polyacrylamide, another product in the past?
Polyacrylamide is a real problem.
Which is Aquamide or other.
As long as it's silicone, you just have a fibrosis. You just have, you can have a granuloma reaction. But anyway, there is no liquid in the tissue. If you have Aquamide or Formacryl or some stuff on that, you have a lake of product, and if you go inside, you will create a reaction, infection,
and this will be the biofilms, which are going to give a more chance, actually not a real chance, for the granulome creating around the product to be much more bigger and to have a bigger lips, and will be all the problem on your shoulder, not on the previous surgeon or previous injector.
Yeah, you know that plastic surgeon, if you touch last, it's your fault. So be careful when you treat this patient, especially because you have to deal with the probable infection, and then if you can manage the infection, sometimes you have some problems after, because you have holes, deformation, and you have to manage that. And be careful, because most, I wouldn't say all, but most of the aesthetic patients are liars. They don't tell the truth. So they come to your office. I saw a lady last week. She came for a liposuction. I look at her and I see she already had the liposuction. I ask, when did you have your first liposuction? Never. So you can tell your husband that you never had one. Okay, but not your surgeon. That's crazy. And they lie, always lie. They will tell you that they had hyaluronic acid in the lips, and I had this treatment 10 years ago.
And it's still effective. The lips is still high. That means it's excellent hyaluronic acid before. No, be careful, because for sure it was silicone.
But be careful, mostly because most of the patients, they are really liars. Because they don't want to tell you that they went to another doctor. They don't want to tell you that. I saw a lady who is a marketing manager or something. She was there for...
They are by profession liars, no marketing people.
She was there to speak with a colleague of mine who's a gynecologist. And after that, you Dr. Salti, I have to see you because I know you're good. I never had anything. Well, she was puffy. Okay, don't tell me. Be quiet.
But in Italy, you have a lot of Rai Uno image of the big lips and big malar region. 10 years ago, it was really a boom.
Yeah, but
now you are playing with this, with laser, with granuloma in the lips.
Actually, the granuloma, it's very difficult to manage with lasers. I know that a good friend of mine, Daniel Cassuto, is always making advertising of this technique, but I tried several times, and I have to say it's very, very difficult. And be careful, because if you do laser in a granuloma, and you don't know how to manage the energy of the laser, you risk to have a scar, and the heating of the tissue can be important, and it can be dangerous. So in those cases, you can refer your patients to Daniel Cassuto in Milan, but he is never in Milan because he travels all the world.
That means it's not a solution. Let's talk about the patient discussion with 3D photos. Do you use this technology? It's useful for you?
No. I use the 3D Vectra system, but not your system that is fantastic. The 3D camera is really useful, not just for you and for your documentation, but even for the patient, because you can show the volume augmentation that you have, or the volume reduction. If you're doing a lipolytic solution, for example, you can show the reduction of the volume or the augmentation of the volume, because they is an objective measurement. You see, I injected 2 ml here. You see after the treatment that you have 1.7 plus, so it means that almost the gel did its effect. So I think that with time, as we move from a very simple way of treating our patient to a more scientific level, everyone in this business should have a system of this kind, that it's expensive but not so expensive. You can afford it, and it's very useful for documentation, even for the standard of practice of photographs. So now all the photographs should be with the same lights and so on.
We discussed about the 3D documentation with the video 3D, photo 3D, and you also launched a discussion about the approach of some of our colleagues, let's say, with less imagination and 3D vision. How important is the 3D examination of the patient and 3D injection of the products? Please explain me a little bit.
I think this is fundamental. I mean, when we do injection, our world is 3D. So our patients are injected 3D because my view is 3-dimensional. So what I tell my colleagues, especially females,
in trainers, in training courses.
Yeah, yes. There are a lot of female doctors who inject themselves on the mirror. The mirror is 2D. You don't see the depth, you don't see the roundness, and you have to work on the reverse because the image is reversed. And only dentists
you can manage one zone, but the other one is quite difficult because of the position of your head.
Only dentists are used to work reverse because they work with mirrors. But we are not used to work with mirrors. So when you do yourself in the mirror, you are 2-dimensional. So it means that you can inject too much. And we see it. If we go to Monte Carlo meeting, everywhere we see a lot.
It's full of this, yeah.
And sometimes you don't have the right control of, because if you use your right hand, you're okay from this side. If you're not okay from the other side, like he was saying. So 3-dimensionality is very important, and that's why it's important that a good colleague that you trust will treat you. Because it's very difficult to treat.
This is a very important observation, but also you as an injector, let's say injector, but as a doctor, injector is not a good word for my point of view, because you are not just simply injecting. You should go around the patient to see different position. Let's talk about this. Bird's eye position, malar position on both sides, going on the top of the patient, going in different, looking. This is important.
This is important. It's like
and marking before.
Yeah, like when you do a liposuction, you do your markings, then you ask your patient to do this, and you see that the marking moves. So this is important because even the area of the face can have smaller, but some movements, and you should see from different positions, especially when you do lips. Always check from the lateral, and always ask your patient a kiss after the treatment to judge for symmetry, because movement can change the results.
And also changing the position, especially for the lips, not upper lip, but for the lower lip, you should go the other side if you want to really to have the right, but if you are right-handed user.
And for the lips, it's very important to address the lower lip. He was saying a perfect point. Most of the patients, they ask for upper lip. In the white race, in the Caucasian race, the upper lip is always smaller. If we make 1-to-1, it's wrong. So people will judge. And the best result in aesthetic surgery is when you cannot judge. When you see a good results without understanding that this is done, it means that the result is okay. If you can judge, it means that you've gone over.
Then if you are going to see the fullness of the malar region, actually starting from pre-injection point, when it's empty, you should stay from the lateral view in the bird eye view, and then going on the patient head and looking both sides with the light
In front.
In front. This is
not
another.
From the side.
Not from the side. Then with headlamp, glasses, mirror or lamp with enhancement to magnification. This is another important thing. And then with or without a good light in the region to see the vessel, especially in the lateral crow's-feet region, where it's very dangerous, especially for Botox injection, but also for fillers.
No, these are good points, and they are technical points, and I think that most of the people in this business thinks that doing injection is easy, so they do injection coming out of the operating theater and do, okay, come on after the surgery, and sometimes they do perfect surgeries and they go wrong with fillers. That's stupid, because even fillers, they need to be respected. They are a big part of plastic surgery today, and we should approach fillers from a scientific point of view, and making this understood by the patient, because most of the patients, they think that this is a stupid treatment, that everybody can do it, and they go and choose the cheaper doctor because they think that everybody does the same. It's not the same. So a Botox that I did is different from a Botox that he did, is different from a Botox that you did. So it's not the product, it's the hand.
Let's talk about one very important complication around the eyes, especially lower eyelid, the tear trough treatment, which is let's say, not that only the tear trough, we are talking about the whole middle part of the passing between the lower eyelid and the malar region, where if you are injecting too much, or if not too much, but you are injecting a little bit higher the orbital rim behind the septum, you are going to increase the puffiness of the lower eyelid. And this is very important to be discussed from 2 points of view. Number one, when it's a swelling and for how long, and when it's a real product, to start thinking about injection of hyaluronidase. Please. It's important for us, but it's a book discussion point.
This is a good point, because up to the 90s, the main request was the nasolabial fold. Now the main request is the midface and the tear trough. And this is a very tricky area from the anatomy, so we should respect the anatomy. There are fat, muscles, and septa, and we should respect. So basic points for me is to always stay deep and touch the bone, avoiding the malar bag, avoiding the malar mound. It's much better not to inject the malar mound. If you want to inject the area of the malar mound, stay deep. But I prefer to inject the lateral SUF, a little bit in the mid SUF, and under the malar bag. Because with these 3 points, I think now there is a strong agreement between surgeons and
3 points. I'm going a little bit to present the theory of 3 viaducts in treating the midfacial region, which is really safe, because it's also keep recording the amount of the volume injected. Very important thing when you are going to see your patient and to understand if you did a good job or a wrong job is to know how many 0-point mils you injected for each point in which area, because this is reproducible. If something wrong, don't do it. If it's excellent, go for it.
And it's always recommended to undercorrect this area. I undercorrect about 70%. So I always tell my patients, this is not the final result. I will see you again in 1 month, and then we will see the result, and we can make it perfect after. So don't expect result from the first treatment.
But if it's still a problem, not swelling, and you are going to see it because of the product, you've gone in the wrong region. What are you doing, and when, and how?
If you see some swelling, especially with Tyndall, it means the bluish discoloration. It means that you injected too superficial, probably, and you injected in the cul-de-sac of the malar bag between the ligaments. So in that area, if you're superficial, you clog the lymphatic, so it blocks the lymphatic drainage, it swells, and you cannot release the water from the area. So in that case, we can, because there's an anatomical study on cadaver where they injected under the muscle, and they were 100% sure that they were under the muscle, and they saw that in 12 cadavers, in 6 or 7, they have some flow back of the filler through the muscle fibers, because the muscle fibers sometimes
in the old people
sometimes they are not continuous,
yes, that's
and
for
they
sure.
are very thin. So even if you're sure that you're on the bone, you can have a little bit of flowing back of product. So that's why it's useful to inject very little amount and wait. But if you see that you have some swelling and
after 3 weeks, 1 month,
yeah,
if she's coming back, and what do you recommend, and how you are preparing the hyaluronides? I know that Italtrade, they have also hyaluronides available, yeah?
Hyaluronides is a very tricky drug, but you should know how to use it, because...
But you should have it just in case.
No, I think that you should have hyaluronides, nitroglycerin paste or nitroglycerin patch, and these are 2 basic things that you should have in case of vascular compromise, because you should inject immediately hyaluronides and put nitroglycerin patch to improve the circulation in that area. But in case you see that you need hyaluronidase for a nodule or for a too large injection, hyaluronidase is measured in units. It's not a droplet. We say sometimes in meetings, oh, you inject a droplet. How much is a droplet? So hyaluronidase is units. It's like botulinum toxin, and
the vial it's about 500, I don't know.
It depends.
100.
It depends, because there are vials that comes from UK. They have 1,500 units. Vials that comes in Italy, they have 300 units.
And Italtrade, they have how many units? 125. They came from Italy probably, but it's not 130.
Okay.
Because
anyway,
they lost a little bit coming from Romania.
It's very important that you know what you're using, because it's not a droplet. If you use a droplet and you have 1,500, one droplet can be 100 units. If you use a vial who has 100 units, one droplet can be 10 units. So it can be very different. So
average, you are using how many units?
Yeah. First, know how many units you have in the syringe. Second, there are some studies that show that the dissolution of products require about 100 units to dissolve 1 ml. If you use a very cohesive gel like Juvederm or Emervel, you need a little bit more because they are cohesive. If you use to dissolve Restylane or Perlane, you need less because they have particles, they are not very cohesive. So I would say 50 to 100 to dissolve 1 syringe of Restylane.
If you have in the tear trough area 0.5, that means you need 50 units.
I didn't show here. I had one patient who was unsatisfied after doing the upper lid with fillers. After 1 week, she came back complaining that she was not satisfied and she would like to remove the product. So I just injected 10 units of hyaluronidase and the product dissolved immediately. But you have to do
immediately means hours, important.
Hours, 2 days.
2 days, yes.
You have to do it when you are sure that you have the product, because sometimes with this almost permanent volumization that comes from the bone, this is not hyaluronic acid anymore. This is bone, so you cannot dissolve that. So use it only when you are sure that you are injecting hyaluronic acid. And hyaluronidase targets hyaluronic acid. Doesn't matter which brand. You need a little more for Emervel or Juvederm, a little less for Restylane.
This is a very important observation.
And
because if you have a patient with no history of the product, inject some amounts of, if it's hyaluronic acid, it's going to dissolve.
To shrink, yeah.
To shrink. If not, stay away because it will be a trouble.
That's silicone probably. And there is a paper in 2 months ago in dermatologic surgery by Claudio De Lorenzi, who is a plastic surgeon in Canada. he was able to show that hyaluronidase can cross the vessels. So if you inject it by chance into a vessel, it's useful to inject all the area around, because hyaluronidase can cross the vessel and go inside. You can dissolve an embolus of hyaluronic acid even into the vessels. So in case you have a vascular compromise...
This was another question about vascular compromise and risk, because this is for the tip of the nose or for the glabellar region.
And back to the original point, I think that nerve are not a real problem. You can touch a nerve; they will do
the immediate pain.
Yeah, they will have pain, but usually when we deliver the local anesthetic, we want to go to the nerve. So we are used to go to the nerve. If you touch the nerve, they will do this, and can have pain for some time. But you can avoid that area, because if you compress the nerve with the product, they will have a strange sensation for 6 months, 1 year. But the real problem is the arteries. If you clog the artery, what you see...
Which is really the problem in the glabellar region, or the...
All the course of the fascial artery, from the premasseteric area here, to the corner of the mouth, to the nasolabial angle, to the nasal artery, to the canthal angle, to the supratrochlear. This is the dangerous area, the most dangerous area. There's a new danger area that is the temporal artery now.
Which, because of the extension to the temporal area injection.
But this area, the fascial artery, the course is the most dangerous.
Which means practically use blunt cannula or inject when you pull out.
Yeah.
And syringe.
Always, if you inject, go deep, always aspirate. There is a debate about aspirating, because someone say, the needle is too thin, you cannot aspirate. The gel is too strong, you cannot aspirate. That is not true. If you catch a vessel, especially an artery, you will see the blood flowing back in the cone of your needle. So be careful and always aspirate a bit. If you don't see nothing, you can inject. But this is a good point to respect the anatomy. And when you inject the nasolabial, don't go too deep to the bone here, because the vessels are on the bone. If you go to the canthal angle, usually the artery is medial and deeper.
That means you should stay lateral.
Yeah, the vein is more lateral. So if you touch something, probably you touch the vein. Sometimes you see the vein. The artery is usually down. But anyway, you don't need to get to the canthal angle. You can get here because you're over the muscle. You can push the gel and spread it a little bit if you want to go to the canthal angle.
Around the eyes, if it's possible, stay or with the perpendicular bridges with the needle, or it's better with the blunt cannula. Protect with the finger, yes, the orbit margin, because you should stay away from the septum and not inject it before the septum.
If you inject beyond the septum, you go into trouble, because you will have swelling for long time. Sometimes you need the surgery to remove the product. When you inject the lip, you have more or less 3 levels of injection. The contour for small lines and definition of the contours. You can do this traditionally with a needle along the contour. I still do that. If they have want some eversion, some volume, you can treat the mucosa at the border of the dry and the wet mucosa with a little bit of volume, just to create a little bit of projection. If they want to have volume and upper rotation, my approach is to inject from inside, retromuscular, with a cannula from the lateral point of approach.
In the commissure, or a little bit out of the commissure?
A little bit out of the commissure. Be careful, because this is an area where sometimes you have vessels. So cannula is useful.
And I've seen after several injections with the commissure, you are going to see a small hole, retracted area, which is really not very nice.
And sometimes if you inject too much the lips, sometimes you get small telangiectasia on the border or on the contour of the lips. But I inject the beyond the muscle. I rotate the lip, and I inject the area that push over the teeth, so that you get some elevation.
I still remember this technique with 3 lines. It's called pari-lip technique, which is really whatever. But it's very important thing to consider that if the lip is short,
yeah,
you can't really make a big thing with this because it's like a small people. If you're going to be fatty with 5 kilos, this will be very unnatural and very ugly. If it's a long lip, you have a bigger chance to give a nice lip. But another important thing, rotation now, like for combination of the lateral eyebrow, botulinum toxin and filler, on the upper lip, we are considering more now the lip lifting.
the lip lift, but
which is really
very
nice.
I think that
In small and without...
if you have a short prolabium, usually the lips is beautiful because it's short.
If it's long, you should combine.
If it's long, you know that aging, it becomes longer and longer. Sometimes it's difficult to make it shorter. Sometimes you can do the commissure. Sometimes you can make it a version. Sometimes you can put a droplet of 1 unit, 2 units of Botox. But sometimes it's better to make a shortcut under the nose and reduce surgically.
Yes, it's a very useful and trend technique, half an hour in the surgery room for the people who are going to the operating room for combining with the fillers. But as for the breast augmentation, we are not talking about one breast, we are talking about 2 breasts. In the lip, we are talking about 2 lips.
Yes.
That means if you are going to see the upper lip and you are not considering the lower lip and the commissure, you are going to have probably an unsatisfactory result.
Most of the ladies come in the office and ask for the upper lip. And what you have to do is you have to do the lower lip first, always. If you do the lower lip, your lower lip will give you the proportion of the upper lip. Consider that the upper lip is about 0.7, about 70% of the length of the lower lip. So do first the lower lip, then according to the volume of the lower lip, you will have the volume for the upper lip. Especially if you do the upper lip first, what happens sometimes is that you use 0.6, 0.7 of your syringe, and you're left with very little, so your lower lip will be little treated and will result a duck bill. So I always treat first the lower lip and then I measure what is left for the upper lip.
And then on the upper lip, you should be very careful with the middle part because if you are going to put too much product, you are going to increase it and will be very ugly. It's like typical for the people who are using instruments.
And always check the symmetry by asking a kiss from your patient. And always check from the lateral side to have the Steiner's line from the tip of the nose to the chin, touching both lips. From a rheologic point of view, Emervel lip is something in between Emervel Classic and Emervel Deep. Particles are slightly bigger than Classics, but they move very well together, so they are soft and create a good definition. But it's soft gel, and especially for lips, I think that duration is important, but it's much better to have a beautiful lip that you have to redo after 6 months than an ugly lip that stays there for 1 year.
There is a difference between men and women in terms of injection, amount of cc injected, the area, where it stays longer, where it stays less, men and women.
Yeah, usually men have stronger muscles, so especially in very movable areas, I mean like glabella and the area around the eyes.
Are you injected? How many % of your patients are men and in this kind of procedure?
I would say about 10% in my practice, 10-15% are men, but they are growing up. But they are very easily to characterize. They are mostly young guys, around 30. They are gym, discotheque, they are very fit. They want to be the best on the beach. Second, they are middle-aged guys. They have the middle-age crisis. They begin to take Viagra. They buy a Porsche or a Ferrari, and
which is a sort of Viagra too.
They change their wife. They take a 25 girl, and they get some injection, and then there's.
But they are not coming back.
And then there's the final group is the gay people. They have a very feminine sensitivity, and they want to have even too much sometimes, but they are very loyal and they are very good customers.